I signed the hospice paperwork myself. I was the attending physician on duty. I reviewed the consent, confirmed the DNR, and documented the transfer as appropriate. And I still don't know who I helped die. My name is Dr. Naomi Calder. I'm 47 years old. And at the time this happened, I had been practicing hospice and palliative medicine for just under 20 years. I wasn't new. I wasn't careless. I wasn't looking for meaning in places it didn't belong. Hospice, at least the way it's supposed to work, is built on clarity. You don't guess. You don't improvise. You make decisions based on what's written, what's signed, and what's medically reasonable. That's why this case stayed with me, and it didn't begin dramatically. No alarms, no frantic calls from a hospital floor, no family screaming in a hallway. It began the way most hospice cases do, quietly, with paperwork arriving before the patient. Transfer notes, medication lists, a prognosis that had already been agreed on by multiple doctors at a hospital I trusted. I remember skimming the chart and thinking, this one won't be complicated. That thought should have worried me more than it did. I worked at Pinewood Haven Hospice Center, an inpatient facility outside a small Oregon city. We handled patients who were too unstable to go home but no longer candidates for aggressive treatment. The staff was experienced. The nurses knew the rhythms of dying better than most physicians ever will. The system ran on routine because routine is what keeps end-of-life care humane. People assume hospice is emotional chaos. It isn't. It's structure, it's forms. It's confirming the same decisions again and again so no one crosses a line they can't step back from. On the night this case began, I was covering admissions. A man named Richard Hale was being transferred from a regional hospital after a prolonged cardiac arrest, 63 years old, severe hypoxic brain injury, poor neurological prognosis, not brain dead but not expected to recover meaningful awareness. His wife and adult son had agreed to hospice after 3 neurologists gave them the same answer. Nothing about that was unusual. What was unusual was how quickly the certainty settled in. I reviewed the transfer documentation while the nurses prepared the room. The consent was complete, the DNR was signed properly, there were no conflicts noted, no pending legal questions. From an administrative standpoint, it was clean. That matters more in hospice than most people realize. I signed the admission orders and moved on. Here's the part that still bothers me. When I signed those papers, I felt relief. Not emotional relief. Professional relief. The kind you feel when a case fits the system you've built your career around, when everything lines up the way it's supposed to. That relief didn't last. I first saw Richard a few hours after admission. He was breathing on his own, shallow and irregular, the way patients with severe brain injury often do. His eyes were closed. He didn't respond to my voice. His vitals were consistent with the transfer notes. If I had been asked at that moment to defend the admission in front of a review committee, I could have done it without hesitation. I documented the exam and left the room. Later that night, a nurse mentioned something small. She said his eyes had opened briefly when she adjusted his position. She didn't sound alarmed. Neither was I. Minimally responsive patients do that. Reflexes can be misleading. We're trained not to read into them. Still, I made a note. The next morning, I returned to the unit and reviewed the overnight logs. No acute changes. No distress. No family concerns. Everything was stable in the way hospice stability usually means waiting. When I went back into Richard's room, I spoke his name out of habit. Patients hear more than we think, even when it doesn't matter anymore. His eyes opened. Not a flutter. Not a reflex. He looked at me. I didn't say anything at first. I waited for the moment to pass. It didn't. He didn't speak. He didn't try to move. But his gaze tracked me as I stepped to the side of the bed. That alone didn't mean recovery. It meant something didn't fit neatly. I stepped out and asked a nurse to observe with me. She saw the same thing. No interpretation, just observation. This is the moment where I want to pause, because this is where people usually jump to conclusions. I didn't think he was waking up. I didn't think we had made a mistake, and I thought we were seeing the edge of what severe brain injury can look like. That explanation held for about 12 hours. During that time, Richard responded appropriately to his name every time it was spoken. He didn't answer questions, but he reacted to tone and direction. When a nurse said, "I'm going to adjust your pillow," he grimaced before she touched him. That doesn't sound impressive until you realize how specific it is. I checked the chart again. I checked the transfer summary. I checked my own notes. Everything still supported hospice eligibility. At this point, if you're wondering why I didn't escalate, that's a fair question. Here's the honest answer. In hospice, escalation doesn't mean treatment. It means paperwork. It means reopening decisions families believed were final. It means uncertainty, where certainty was promised. Before I go any further, let me ask you something. If you've worked in healthcare, especially in hospitals or hospice, tell me in the comments if you've ever trusted the system more than your own instincts. And if stories like this matter to you, subscribe to the channel so you don't miss the ones that don't come with easy explanations. By the end of that first day, Richard did something I couldn't document as a reflex. When I asked if he was in pain, he shook his head. Once. Deliberately. I stood there longer than necessary, listening to the steady sounds of a unit built for endings, realizing that the most unsettling part wasn't that he might be aware. It was that I had already agreed on paper that awareness no longer mattered. I stood by the bed longer than I intended, my hand resting on the rail, listening to the rhythm of his breathing, until the unit noise pulled me back into motion and reminded me I still had a job to do. Hospice medicine doesn't give you the luxury of curiosity. It gives you rules, clear ones. The moment a patient is admitted, the goal narrows. Comfort only. No reversals. No investigations meant to change an outcome that has already been accepted. That structure is what allows families to let go without feeling like they've abandoned someone they love. People outside medicine think hospice is about death. Inside, it's about limits. Limits on treatment. Limits on intervention. Limits on how much doubt you're allowed to entertain once consent is signed and documented. Every admission starts with the same quiet checklist. Confirm the DNR. Review the prognosis. Make sure the family understands that nothing we do is intended to prolong life. Nurses reinforce it. Social workers repeat it. Physicians document it again. Redundancy isn't wasteful in hospice. It's protection. That night, after leaving Richard's room, I opened his chart at the workstation and read it line by line. Not because I expected to find something new, but because the act itself steadies you. Notes from the hospital were concise. Severe hypoxic injury. Minimal chance of meaningful recovery. Comfort-focused care recommended by neurology. Family in agreement. There was no language of uncertainty, no hedging. That's what makes hospice transfers easier. Ambiguity creates guilt. And guilt is poison in end-of-life care. The nurses rotated through their tasks with the practiced calm of people who know what comes next. Medication schedules were set. Repositioning times were logged, mouth care, skin checks, the rituals that replace intervention when intervention is no longer appropriate. I checked in with the charge nurse and confirmed there were no concerns from the family. His wife had stepped out to get food. His son had gone home for the night. They had already begun the slow withdrawal families make when they've accepted that waiting is all that remains. From a systems perspective, this is where things are supposed to stabilize. Hospice patients don't get better. They plateau briefly, then decline. That's the pattern the entire structure is built around. Deviations are rare, and when they happen, they're usually small. A little more responsiveness. A few lucid words before the end. We call them rallies. They're expected, and they don't change the plan. I told myself that's what I was seeing. But hospice also teaches you to be precise with language. A rally is fleeting. It doesn't track consistently. It doesn't respond reliably to stimulus. It's a flicker, not a signal. What I saw with Richard didn't flicker. When the nurse came to administer medication, he reacted before the needle touched his skin. Not with a startle reflex, but with anticipation. He tightened his jaw. His eyes narrowed. That kind of response implies awareness of cause and effect. It implies expectation. I didn't document that yet. I waited. In hospice, documentation isn't just record keeping. It's a legal narrative. Once something is written, it defines the reality everyone else must operate within. If you write awareness, you invite questions that don't have comfortable answers. I stepped back and let the nurses continue their work. They noticed the same things I did. They didn't say much. Experienced hospice nurses don't speculate out loud. They report facts and wait to see how physicians interpret them. By morning, I had made a decision that felt small at the time. I would observe before I acted. Observation isn't neglect. It's caution. Acting too quickly in hospice can do more harm than doing nothing. During rounds, I explained the admission to the oncoming team. I used the same language as the chart. Severe injury, comfort care, no escalation planned. I didn't mention the eye contact. Not because I was hiding it, but because I didn't yet know what it meant. Hospice operates on shared understanding. When you disrupt that understanding, you carry the burden of proof. Later that day, I met briefly with the social worker assigned to the case. She had spoken with the family again. They were tired but calm. They asked appropriate questions. They didn't ask about recovery. That matters. Families who sense possibility cling to it. This family had already let go. Their acceptance made everything else harder. When I returned to Richard's room, I spoke to him again quietly, the way clinicians do when they're not sure who's listening. I explained where he was. I explained what hospice meant. I didn't expect a response. The explanation was for my own sense of professional completeness. He didn't speak, but his breathing changed as I talked. Slower, more regular. When I finished, he exhaled sharply, almost like a sigh. That was the moment I felt the rules pressing in around me. Hospice is built to remove choice once choice has been exercised. The system assumes that once a patient reaches this point, clarity has already been achieved somewhere upstream. Our role is to honor it, not revisit it. Standing there watching a man who appeared to understand words that were supposed to be irrelevant to him, I realized how little room hospice leaves for revision. The nurses continued charting monitors, ticking softly, the ordinary mechanics of hospice, filling the space where questions tried to form. I told myself that clarity was not the same as certainty, and that my role was to follow what had been agreed upon, not to interrogate it. The unit moved forward on schedule, and I moved with it even as the sense of alignment I depended on began to thin. It wasn't fear yet. Pressure like a rule being bent without breaking. I closed the chart and signed off on the day's orders, choosing structure over uncertainty, and trusting that the framework designed to protect patients would absorb whatever discomfort I was feeling without asking me to name it. I signed into the system again before the coffee had cooled, pulling Richard Hale's chart back up on the screen. Not because anything had changed overnight, but because I needed to see the story the hospital had already told me one more time. The transfer summary was clean, almost aggressively so. Aggressively, 1 cardiac arrest at a job site. Estimated downtime just under 10 minutes before return of spontaneous circulation. Intubated in the field. Admitted to the ICU. Neurology consulted within 24 hours. MRI consistent with severe hypoxic injury. EEG showing diffuse slowing. Prognosis documented as poor by 3 separate physicians. When hospitals send patients to hospice, they usually hedge. Words like guarded, uncertain, limited recovery potential show up everywhere. Richard's chart didn't hedge. It closed the door firmly and locked it. That should have been reassuring. The hospital itself was one we worked with often. Mid-sized, well-staffed, no reputation for cutting corners. I recognized 2 of the attending physicians who had signed off on the transfer. Competent, conservative, not prone to dramatic calls. I scrolled through the timeline, watching the days compress into neat blocks of notes and orders. Pressors weaned, ventilator removed. Nutrition discontinued, comfort medications initiated. The moment when treatment shifted from rescue to acceptance was clearly marked like a line no one had stepped over without agreement. There was nothing there that suggested error. The family meeting note caught my eye mostly because of how brief it was. Wife present, adult son present. Prognosis explained. Goals of care discussed. Hospice recommended. Family in agreement. No dissent documented. No follow-up requested. I've sat in hundreds of those meetings. Usually they take pages to summarize, not because the information is complicated, but because emotion is. Families ask the same question 10 different ways, hoping the answer will change. This family hadn't done that. I leaned back in my chair and rubbed my eyes, irritated with myself. Acceptance doesn't look the same for everyone. Some people arrive at it quickly. Some people are relieved when someone else finally says what they've already known. I closed the family note and opened the medication reconciliation. Everything matched what we had on hand. Morphine, lorazepam, anti-secretory agents. No outliers, no odd additions. By the time I walked back onto the unit, the nurses were settling into the day. Linen carts moved down the hall. Someone laughed quietly at the station. Hospice doesn't feel like a hospital when it's running smoothly. It feels suspended, as if time moves differently here. Richard's wife arrived mid-morning. She introduced herself without hesitation, as though she'd practiced it. She was composed, but not distant. Tired in the way people get when they've been bracing themselves for weeks. I explained the plan again because that's what we do even when families already understand. Comfort-focused care. Symptom management. No invasive interventions. She nodded through all of it. When I mentioned that he seemed to be more responsive than expected, her expression didn't change. She didn't look hopeful. She didn't look confused. She said, "He's always been stubborn." It was a throwaway comment meant to lighten the moment, but it landed wrong. Stubborn implies intention. It implies resistance. I asked if she wanted to spend time alone with him. She said she already had, that she preferred not to sit in the room for too long. She thanked the nurses, asked about pain control, then stepped out to make a phone call. Families often pull back at this stage. Being present doesn't always feel like comfort. Sometimes it feels like witnessing something you can't change. When I went back into Richard's room, he was awake again. His eyes were open, tracking the movement near the window. When I spoke his name, he shifted his gaze toward me. I asked simple questions, the kind that don't invite false positives. "Can you hear me?" He blinked once. "Can you hear me?" He blinked again. Blinking can be coincidence. Repetition reduces that possibility. I asked him to blink twice if he understood where he was. He didn't. That mattered. Awareness isn't binary. It exists on a spectrum, and I didn't want to overstate what I was seeing. But when a nurse entered the room and said she needed to adjust the bed, he tightened his hands on the sheet before she touched him. Anticipation again. I stepped back and watched without directing anything. The nurse finished her task and looked at me, her expression neutral but questioning. She didn't say a word. She didn't have to. I documented what I could without interpretation. Eyes open spontaneously. Tracks examiner. Withdraws in anticipation of stimulus. Clinical language creates distance. It also creates a record that can't be easily dismissed. After lunch, I received a call from the hospital case manager who had coordinated the transfer. She was following up, making sure the admission had gone smoothly. Her tone was routine, friendly. She asked if we needed anything else. I almost said no. Instead, I asked a question that surprised both of us. I asked how confident they had been in the neurological prognosis. There was a pause on the line just long enough to register. She said, "As confident as we can be in these situations. There was no meaningful improvement during his ICU stay." I thanked her and hung up, annoyed with myself for expecting something different. By late afternoon, Richard responded appropriately to his name every time it was spoken. He didn't answer questions, but he reacted to voices with consistency. Nurses began spacing their movements more deliberately around him, adjusting the room the way you do when you're no longer certain no one is watching. The unit adapted without discussion. That's what experience looks like. As evening approached, I reviewed the chart again and confirmed there were no standing orders that conflicted with what I was observing. Everything still fit within hospice parameters. No policies were being violated, no lines crossed. That was the most unsettling part. The system allowed for this. It absorbed the anomaly without resistance, the way it absorbs everything else that doesn't demand immediate action. I finished my notes, signed off on the day, and walked past Richard's room one more time. He was awake, staring at the ceiling, breathing evenly, a man the hospital had declared beyond meaningful awareness, lying quietly inside. A decision that had already been made for him. I didn't leave the unit when my shift technically ended, choosing instead to sit at the workstation and watch the flow of notes update in real time. My attention drifting back to Richard's room more often than I wanted to admit. Hospice awareness is a careful concept. It isn't about consciousness in the way ICU medicine defines it. It's about responsiveness that changes how care is delivered without changing the outcome. That distinction matters because hospice is not designed to chase neurological questions. It's designed to manage symptoms, while time does what it's going to do anyway. Richard's awareness didn't announce itself all at once. It crept in through details small enough to ignore if you were inclined to. He responded faster to familiar voices than unfamiliar ones. His breathing pattern shifted when someone entered the room even before they spoke. When a nurse approached from the left side of the bed, his eyes tracked left. When someone spoke from the doorway, his gaze followed the sound. None of this violated hospice eligibility on its own. Minimally responsive patients can display islands of awareness. The problem wasn't the behavior. It was the consistency. By the second evening, the nurses had begun to adjust how they spoke around him. Not consciously, not discussed. It happened the way clinical habits do, quietly and without permission. Voices lowered, explanations were offered before touch. Tasks were announced instead of performed in silence. Hospice nurses are practical people. They don't sentimentalize awareness. If a patient can hear you speak respectfully, if they can't, you still do. The difference is subtle, but it changes the room. During evening rounds, I stood at the foot of Richard's bed and spoke through the standard assessment. Pain, breathing, comfort. I didn't ask open-ended questions. I didn't test him. I watched. When I asked if he was comfortable, he shifted his head slightly, then stilled. When I asked if he was in pain, his brow tightened. When I asked if he wanted medication, his eyes closed briefly, then reopened. That response was not definitive. It was also not random. I documented it carefully, choosing words that described movement. without assigning meaning. Hospice documentation is an exercise in restraint. You write what you see, not what you think. Later that night, a nurse charted that Richard had reacted before a blood pressure cuff tightened. Another noted that he appeared to calm when spoken to, even if he didn't respond verbally. The notes stacked quietly, none of them alarming on their own, but together they formed a pattern that was difficult to ignore. Patterns are dangerous in hospice. They invite questions that don't have actionable answers. I reviewed the admission criteria again, making sure I wasn't missing something obvious. Hospice eligibility doesn't disappear because a patient becomes intermittently aware. It disappears when there's evidence of recovery that could change the trajectory of care. Richard wasn't recovering. He wasn't improving. He was simply present. Presence complicates things. I spoke with the charge nurse about staffing assignments, suggesting we keep more experienced nurses on Richard's room. Not because he required special care, but because inexperience creates uncertainty, and uncertainty spreads. She agreed without asking why. By the third day, Richard began reacting not just to people but to conversations. When nurses discussed medication timing outside the room, his breathing shifted before anyone entered. When a social worker mentioned his wife by name at the station, his eyes opened in response to the sound. I stood in the doorway and watched it happen. My badge clipped at my waist, my chart in hand, my role suddenly less defined than I liked. I told myself that sound travels, that the brain even injured can recognize familiar stimuli, that none of this proved comprehension. That explanation held until the morning medication round. I was present when a nurse prepared to administer morphine. She explained the dose out loud, as she always did. Before she touched the syringe, Richard shook his head. Not violently, not in distress. Once. Deliberately. The room went still. The nurse froze, her hand hovering, waiting for direction. I stepped closer and repeated the question myself. I asked if he wanted medication for comfort. He shook his head again. The moment forced a choice I wasn't ready to make. In hospice, refusal matters if it's informed. Reflex doesn't count. Ambiguity defaults to comfort. That's how the system protects patients who can't advocate for themselves. I chose the system. I ordered the medication to be given at a lower dose, documenting agitation as the indication. The nurse complied, but her eyes stayed on me longer than usual. She wasn't questioning the order. She was measuring my certainty. Afterward, Richard's breathing slowed. His muscles relaxed. He didn't appear distressed. On paper, the intervention was appropriate. In my head, it felt wrong. I spent the rest of the morning reviewing policies, looking for guidance that might not exist. Hospice protocols are thorough about consent at admission. They're less explicit about consent after that point. Once a patient has been deemed unable to participate, decisions default to previously documented wishes and surrogate agreement. Richard's wishes were documented. His family had spoken. Legally, ethically, procedurally, everything was sound. And yet, standing there watching a man respond to questions he wasn't supposed to understand, I felt the boundary between patient and process thinning. I spoke with his wife again that afternoon. I explained that he seemed more responsive than expected, framing it as observation, not concern. She listened, nodded, and said she trusted us to keep him comfortable. She didn't ask to change the plan. She didn't ask to revisit decisions. That acceptance closed a door I hadn't realized was still open. By evening, the unit had settled into its familiar rhythm. Call lights chimed, medication carts rolled, families came and went. Richard remained awake for long stretches, his eyes open, his body still a quiet presence in a place designed for decline. I updated his chart one more time, careful not to overstate what I couldn't prove. Aware that each word I chose narrowed the range of actions available to everyone who would read it later, and conscious in a way I hadn't been before that awareness didn't need permission to exist inside a system that had already decided it didn't matter. I caught myself lowering my voice outside Richard's room before I realized I was doing it the way people do when they believe someone inside might be listening, even if logic says it shouldn't matter. By the fourth day, his responsiveness had stopped feeling like an anomaly and started feeling like a condition the unit was quietly adapting to. Nurses announced themselves before entering. Conversations about medication timing happened farther down the hall. No one said why. We all understood the shift without naming it. Hospice doesn't encourage that kind of adaptation. It's meant to be neutral, predictable. When behavior changes without instruction, it means people are compensating for something the rules don't address. The first time Richard demonstrated knowledge he shouldn't have had it was easy to dismiss. A nurse entered the room to reposition him and mentioned casually that she would be back later to check his blood pressure. Before she reached the door, Richard moved his arm, adjusting it into a position that made the cuff easier to place. She paused, looked at me, then finished her task without comment. That could have been coincidence, muscle memory, random movement. An hour later, I returned with a social worker to update the care plan. We stood just inside the doorway, speaking quietly. Before either of us addressed him, Richard shifted his gaze toward the social worker and tightened his jaw. She hadn't said a word yet. The social worker stepped back instinctively, unsettled enough that she laughed under her breath and said, "That's strange," as if saying it lightly would make it less so. I didn't respond. I didn't want to reinforce the observation by agreeing. Later that afternoon, a nurse charted something she normally wouldn't bother writing down. She noted that Richard appeared to become more alert when specific staff members were nearby. Names were listed, times were included. That was when it stopped being about reflexes. I pulled up the chart and read through the nursing notes in sequence. Each entry taken alone could be rationalized. Together, they suggested something closer to recognition. He reacted differently to different people. He responded more consistently to familiar voices. He appeared to anticipate actions before they occurred. Anticipation implies awareness of sequence. Awareness of sequence implies memory. Memory wasn't supposed to be on the table. I reminded myself that awareness does not equal comprehension. The brain can process patterns without understanding meaning. That explanation works until the patterns become too specific. It happened during the evening medication pass. A nurse approached the room with the cart and stopped just outside the door, checking the screen. She hadn't spoken yet. Richard's eyes opened immediately. His breathing shifted. When she entered and confirmed his name, he nodded. A small movement, barely there but unmistakable. She asked if he was comfortable. He shook his head once. I stepped in and asked what was bothering him. His eyes moved toward the IV pump, then back to me. The pump was alarming, softly, a low-level alert indicating the infusion would need attention soon. He shouldn't have known that. The nurse silenced the alarm and adjusted the settings. The sound stopped. Richard's shoulders relaxed. No one said anything. Afterward, the nurse followed me to the station. She didn't accuse. She didn't speculate. She asked a single, careful question. "Do you think he understands more than we thought? In hospice, that question is dangerous. It opens a door you can't close." I answered honestly. I said I didn't know. That was the last safe answer I had. Later that night, as I reviewed orders, Richard spoke for the first time. It wasn't a sentence, it wasn't even a word that carried much meaning on its own. I was standing near the bed discussing staffing with another nurse when he said my name. Not loudly, not clearly, but accurately. I turned toward him, my pulse picking up in a way I hadn't felt in years. I asked him to repeat it. He didn't. He closed his eyes and went still again, as if the effort had cost him more than it was worth. Names are anchors. You don't say someone's name without knowing who they are. I documented the vocalization. I chose neutral language, patient, vocalized. Utterance appeared directed. I avoided interpretation because interpretation changes everything. The next incident removed any remaining comfort I had in ambiguity. I was reviewing charts at the station when Richard's nurse approached me. her expression tight. She told me he had gestured toward the hallway and said, "Room down there." She assumed he was confused and asked him to clarify. He shook his head frustrated and said, "The woman. She's not going to last." There were 3 women on the unit whose conditions could have fit that description. Hospice is full of people who aren't going to last. That's the point. But less than an hour later, a patient 2 rooms down began to decline rapidly. Her breathing became labored. Her oxygen saturation dropped. She died before her family arrived. I told myself coincidence was inevitable in a place like this. Patterns form when you look for them. Then it happened again. The next morning, Richard mentioned pain before a nurse had assessed it. He tensed before procedures he hadn't been warned about. He reacted to conversations held outside his room, ones he couldn't have heard clearly from where he lay. At one point, he looked directly at me and said, "You're tired." I was. That comment didn't frighten me. It irritated me. It crossed a boundary that made everything else harder to ignore. I reviewed his medication list again, looking for anything that could explain heightened awareness. Nothing. No stimulants, no unusual dosages, no changes. I checked the vitals trend. Stable. No signs of improvement that would suggest neurological recovery. I checked the admission criteria again. Still met. The system had no place to put what I was seeing. It didn't require action. It didn't prohibit it either. It simply absorbed it the way institutions absorb anything that doesn't demand immediate correction. Nurses began asking me questions in pairs quietly away from the station. Not panicked, curious, careful. They wanted to know how to respond if he refused medication again. They wanted to know how much explanation was appropriate. Those questions forced me to acknowledge something I had been avoiding. Whether or not Richard understood, everything he understood enough to complicate consent. And consent in hospice is the foundation everything else rests on. That afternoon, I stood at the foot of his bed and explained plainly what hospice meant. I told him we were focused on comfort. I told him we weren't trying to fix what had happened. I told him the goal was to keep him comfortable and let things take their course. When I finished, he opened his eyes and looked at me steadily. "You already decided," he said. It wasn't an accusation, it was a statement of fact. I didn't correct him, I couldn't. Because what he said was true, and because hearing it out loud forced me to confront how fragile that decision felt, when the person it applied to was no longer as silent as the system expected him to be. I left his room without responding, walking straight to the workstation and pulling his chart up again, my fingers moving faster than my thoughts. Because looking at data felt safer than standing in front of a man who had just described my role more accurately than I liked. The hospital records were the first place I went. Not because I expected answers, but because that's where responsibility usually gets redistributed. If something doesn't make sense in hospice, the assumption is that it was decided earlier somewhere else by someone with a different mandate. I opened the neurology consult notes from the hospital and read them carefully. Severe hypoxic injury, poor prognosis, no meaningful response over multiple days, recommendation for comfort-focused care. It was all there, written plainly without hedging language. I'd read it before, I read it again, slower. The EEG report was attached as a PDF. I clicked it open and frowned almost immediately. The summary page was intact, but the detailed tracing that usually followed wasn't there. Instead, there was a brief note stating that the file was incomplete due to transfer limitations. That happens more often than people realize. Systems don't talk to each other well. Files get compressed. Older data gets summarized instead of copied. It's annoying but not alarming. Still, I checked the timestamp. The EEG had been performed 48 hours after his cardiac arrest, a window when prognostication carries weight. I wanted to see the raw data. I wanted to see what had convinced 3 neurologists to agree so decisively. I called the hospital's medical records department and asked if they could resend the EEG in full. The woman on the line was polite and efficient. She asked for identifiers, confirmed my credentials, and put me on hold. When she came back, she told me the full tracing wasn't available anymore. The summary was all that had been retained during the system migration earlier that year. That explanation should have ended the conversation. It didn't. I asked if that was typical. She said yes. I asked if there was any way to retrieve archived data. She said not without a formal request, and even then there was no guarantee. I thanked her and hung up, staring at the screen longer than necessary. I moved on to the transfer documentation, admission notes, discharge summary, nursing handoff. Everything lined up chronologically, but the more I read, the more I noticed how smooth it all was. No contradictions, no corrections, no late addenda. It was as if the case had passed through the hospital without friction. That's rare. I pulled up the medication administration record from the ICU stay. Sedation had been weaned appropriately. Pain control adjusted as needed. There was nothing there that suggested he'd been over-medicated or artificially suppressed. If anything, the care had been conservative. I walked down the hall to the compliance office, a small room tucked away from patient care areas, and asked if someone had time to talk. The compliance officer on duty was someone I'd worked with before. Calm, methodical, not prone to dramatics. I explained fluffily that I was seeing responsiveness in a hospice patient that felt inconsistent with the hospital's neurological assessment. I didn't use loaded language. I didn't speculate. I framed it as a documentation question. She listened without interrupting, then nodded slowly. She told me that incomplete records during transfers were common, that prognostication is not an exact science, that hospice admissions are based on probability, not certainty. I told her I understood that. I told her I wasn't questioning the admission decision. I was questioning whether all the information that decision was based on was still accessible. She said, "What would having that information change?" It was a fair question. In hospice, the answer is usually nothing. I didn't have a clean response. I said it would help me understand what I was seeing. She reminded me that understanding doesn't always require action, and that reopening hospital decisions after hospice admission can cause unnecessary distress for families. She wasn't wrong. That's the problem with systems designed to minimize harm. They discourage inquiry once a conclusion has been reached. I left the office with no instructions and no restrictions. No one told me to stop. No one told me to continue. The system didn't push back. It simply absorbed my concern without reacting to it. Back on the unit, I reviewed the chart again and noticed another small absence. The initial neurological exam documented reflexes, tone, and response to pain. But the timing was vague. No exact hours, no specific intervals, just generalized descriptors. That level of imprecision is acceptable in a crisis setting. It becomes less comfortable when it's the foundation of irreversible decisions. I called the hospital intensivist who had overseen the transfer. He remembered the case but vaguely. There were many like it. He confirmed the prognosis, confirmed the family discussions, confirmed that hospice had been appropriate. When I asked about the EEG, he paused and said he trusted the neurologist's interpretation. He hadn't reviewed the raw data himself. That wasn't negligence, and that was normal. After the call, I stood at the station and watched the unit function the way it always did. Nurses charted. A chaplain spoke quietly with a family. A medication alarm chirped and was silenced. The system moved forward, indifferent to my discomfort. When I returned to Richard's room, he was awake, his gaze steady. I didn't ask him questions. I didn't explain what I'd found. I adjusted his pillow and checked his comfort, the same way I would for any hospice patient. As I turned to leave, he spoke again. "They don't keep everything," he said. I stopped my hand on the doorframe, resisting the urge to ask who he meant. Hospitals don't keep everything. Records are summaries of summaries. That's not secret knowledge. Still hearing it from him felt different. I documented the statement without interpretation, noting it as spontaneous speech. The chart accepted it without protest, the way it accepted everything else that didn't quite fit, categorizing it without resolving it. By the end of the day, I had exhausted every formal avenue available to me. There were no missing signatures, no policy violations, no procedural errors that could be corrected. What remained was a gap between what had been decided and what I was witnessing, and a system structured to treat that gap as irrelevant once the paperwork had been finalized. I closed the chart, aware that the absence of answers was not an oversight, but a feature, and that whatever was happening in Richard's room existed entirely within the boundaries of a process that had no language for addressing it. I noticed the change before anyone mentioned it, the way the unit seemed to lean slightly in Richard's direction, conversations drifting quieter as they passed his door, staff slowing their pace without realizing why. Hospice units have a rhythm. You learn it early. Patients decline at different speeds, but the environment stays steady. When that rhythm shifts, it's usually because someone is actively dying. This was different. The shift centered on someone who wasn't supposed to be paying attention. Richard had started listening in a way that felt deliberate. It began with timing. He reacted before nurses entered the room, before footsteps reached the threshold. When someone paused outside to review orders, his breathing changed. When a staff member mentioned a patient's name at the station, his eyes opened even if the sound was distant. I told myself sound carried. I told myself familiarity explained it. I told myself none of this crossed a line that required intervention. Then he started commenting on other patients. The first time I dismissed it, almost immediately. A nurse was adjusting his bedding when he said quietly, "The woman down the hall is struggling." The nurse assumed he meant himself and reassured him, explaining that she was there to help. He shook his head, irritated, and said, "Not me. Hospice is full of struggling people." The statement was vague enough to mean nothing. Less than 30 minutes later, a patient 2 rooms away began to decline rapidly. Her breathing became shallow and irregular. Oxygen requirements increased. Family was called. She died before midnight. Coincidences happen constantly in hospice. They're unavoidable. I reminded myself of that and moved on. The next morning, Richard watched me review the assignment board and said, "You should check on him first." I asked who he meant. He nodded toward a room occupied by a man with advanced pulmonary disease. At the time, the man's vitals were stable, no acute distress, no indication that he needed immediate attention. I went anyway. The patient's breathing had worsened since the last check. Subtle changes, but real ones. We adjusted his oxygen and notified his family. He stabilized briefly, then declined later that evening. I didn't mention Richard's comment to anyone. I documented the change as it presented and kept my thoughts to myself. By midday, nurses were watching him more closely, not because he demanded care, but because he seemed to know when care would be needed elsewhere. They didn't say it outright. They asked indirect questions instead. Did I want them to reposition him more often? Did I want them to check in with him before rounds? Those questions weren't about comfort. They were about attention. During afternoon rounds, Richard spoke again. This time, there was no ambiguity. "She won't make it through tonight," he said, nodding toward a room across the unit. I told him not to worry about other patients. I told him to focus on his own comfort. He closed his eyes, unimpressed. That evening, the patient he had referenced developed terminal agitation. Despite medication, despite family presence, she declined quickly. She died before the shift change. I felt something tighten in my chest, not fear exactly, but resistance, the kind you feel when evidence accumulates faster than explanation. I reviewed the charts of the patients he mentioned, looking for commonalities. Diagnoses varied, ages varied, prognoses varied. There was no obvious pattern he could have learned through observation alone. I asked the nurses if they had spoken to him about other patients. They hadn't. Hospice staff are careful about privacy. No one had discussed details in his presence. That night I stayed later than scheduled, pretending to catch up on documentation while watching how the unit moved around him. He didn't speak constantly. He didn't comment on everyone. He only spoke when something was about to change. When he did speak, the comments were brief. No drama, no explanation, just statements. He's tired, she's in pain, you should go now. Each time, the comment aligned with something that hadn't yet been documented but soon would be. I considered every possible explanation that didn't involve anything extraordinary. Pattern recognition, sensitivity to sound, luck, confirmation bias. Hospice is fertile ground for all of those. But I couldn't ignore the way his awareness extended beyond himself. That crossed a boundary hospice medicine doesn't train you to navigate. I spoke with a nurse privately, asking her to tell me if he said anything else. Not because I wanted to act on it, but because I needed to know if what I was seeing was consistent. She agreed, relieved to be asked, as though she'd been waiting for permission to acknowledge it. The next morning, Richard refused medication again. When the nurse asked why, he said, "I need to stay clear." Clear wasn't a term he'd used before, and I asked him what he meant. He looked at me for a long moment, then said, "You don't like surprises." He was right. I don't. That comment irritated me more than the others. It suggested awareness of me, not just of the unit. It suggested observation, not reaction. I told him he didn't need to stay clear for us. I told him comfort was the priority. He listened, then said, "Not yet." That was the first time I felt the balance shift. Up until then, I had been choosing to observe. Now I was being asked indirectly to respond. I documented the refusal and adjusted the plan within allowable parameters. The system accommodated it without resistance. Hospice protocols allow for patient preference, even when that preference isn't clearly articulated. That flexibility is meant to protect autonomy. It can also obscure responsibility. By the end of the day, Richard had commented on 3 patients. 2 died. 1 declined significantly. None of this appeared in his chart beyond my careful, neutral documentation. The nurses began repositioning assignment boards subtly, giving his room more experienced staff the way you do when something feels fragile, even if you can't name why. I caught myself checking in on other patients sooner than scheduled just in case. That behavior disturbed me more than anything Richard said. It meant he was influencing my decisions without ever issuing a directive. Hospice medicine depends on boundaries. When those boundaries blur, you risk turning care into reaction. That night, as I stood near his bed, adjusting his blankets, he spoke again, his voice steady despite the effort it took. "You already know," he said. I asked him what he thought I knew. He didn't answer. He simply watched me, the unit quiet around us, his awareness stretching beyond the space hospice had prepared for him, forcing me to confront the possibility that what unsettled me wasn't that he knew about others, but that he seemed to know how the system itself would respond long before it did. I found myself agreeing to things without realizing when the agreement happened, the way decisions slide into place when the system keeps moving and you move with it. By the end of that week, Richard's chart had become thick with notes that said very little. Comfort maintained. No acute distress. Plan unchanged. The language was correct. It was also increasingly disconnected from how the unit felt around him. Hospice has a way of normalizing whatever it contains. The longer something persists without triggering a formal response, the more it becomes part of the background. Richard's awareness stopped being remarked on and started being worked around. Nurses adjusted, schedules shifted slightly, conversations happened at a distance. No one escalated anything because escalation implied there was something to escalate to. There wasn't. I met with the interdisciplinary team during our routine case review. Nursing, social work, chaplaincy, administration. Richard's name came up like any other. Prognosis, unchanged. Comfort goals, appropriate, family, informed, no barriers to care, identified. I listened as each discipline checked their box. No one lied, no one minimized. They simply reported within the scope they were given. When it was my turn, I summarized the case the way the chart described it. Severe hypoxic brain injury, hospice appropriate, intermittent responsiveness noted, comfort measures effective. I did not say that he had refused medication because he wanted to stay clear. I did not say he had commented on other patients before they declined. I did not say that his awareness seemed to extend beyond himself. Not because I was hiding it, but because there was no category for it. If I had raised those points, the conversation would have stalled. People would have looked at me waiting for a recommendation I didn't have. Hospice meetings are not investigative, they're confirmatory. Their purpose is to make sure everyone is aligned, not to introduce uncertainty. The meeting ended with the usual conclusion. Continue current plan. That phrase followed me back onto the unit. Continue current plan meant continue treating Richard as someone who could not meaningfully participate in decisions about his own care. It meant continue honoring paperwork signed days earlier, based on assessments that no longer fully matched what I was seeing. It also meant that officially nothing was wrong. Later that afternoon, Richard's wife visited again. She sat by his bed, holding his hand loosely. Not crying, not speaking much. When I checked in, she thanked me for keeping him comfortable. She said he looked peaceful. I asked her if she had noticed him responding more than she expected. She nodded, but without surprise. He's always been observant, she said, even when he didn't say much. I asked if he had ever been like this before, aware of other people's moods, other people's needs. She smiled faintly and said he had always known when to leave a room. That explanation was vague enough to mean nothing and everything. I didn't push. Families in hospice don't need interrogation. They need reassurance that nothing is being taken from them without consent. Consent was the word that kept coming back to me. Consent had been given. Consent had been documented. Consent had been reaffirmed. The system treated consent as durable, something that didn't erode with changing circumstances. I spent the evening reviewing hospice policies, again searching for guidance on situations where patient awareness changes after admission. There were sections on reassessment, on revocation of hospice, on transfer back to hospital if goals changed. All of them required clear evidence of recovery or explicit patient request. Richard had done neither. He had not asked to leave hospice. He had not asked for treatment. He had not asked for anything that would force the system to react. He had simply been present in a way that complicated everything, without technically violating any criteria. I checked his vitals again. Stable, no improvement, no decline, a plateau that hospice recognizes as a waiting period. When I went into his room that evening, he was awake. He watched me approach, his eyes steady. I asked how he was feeling. He shrugged slightly. I told him we were continuing the current plan. Comfort, symptom management, no invasive interventions. I didn't ask if he agreed. Agreement had already been documented. He listened without interruption. When I finished, he said, "That's easier for you." He wasn't wrong. Continuing the plan meant I didn't have to explain anything to the family. It meant I didn't have to reopen hospital decisions that were already closed. It meant I didn't have to create conflict in a system designed to avoid it. I reminded myself that hospice is not about fixing discomfort in clinicians. It's about protecting patients from unnecessary suffering. Still, his comment lingered. That night, he slept for several hours uninterrupted. The unit settled into its familiar quiet. Nurses completed tasks efficiently. Families whispered in rooms where decline was expected. I watched the assignment board update for the next shift and realized that officially Richard's case had been absorbed. It no longer stood out. It had been categorized, documented, and accepted. That acceptance was supposed to be reassuring. Instead, it felt like closure without resolution. I finished my documentation, noting no significant changes, and signed off. The system accepted my notes the way it accepted everything else, filing them away, under a plan that no longer required my scrutiny. As I left the unit, I glanced back at Richard's room. He was awake, staring at the ceiling, his breathing, even his presence calm. A man whose case had been closed by every measure that mattered on paper, existing quietly. Inside, a framework that had decided there was nothing left to question, even as the sense that something fundamental had been settled too soon continued to press against the edges of my certainty. I noticed it while helping a nurse reposition him. My focus on the mechanics of the task until a small, pale indentation behind his left ear caught the light. It wasn't dramatic. No scar tissue, no surgical marks, just a shallow dent in the bone, subtle enough that you wouldn't see it unless you were close and looking for something else. I paused longer than necessary, my hand still supporting his shoulder. I had seen that mark before, not on Richard. On the intake photo. I stepped back and finished the repositioning without comment, my mind already replaying the image from the chart. Intake photos are mundane things taken quickly, meant to confirm identity, not to document anatomy. Still, the absence of that indentation in the photo bothered me more than its presence on his body. At the workstation, I pulled up his EMR and navigated to the admission tab. The photo loaded, slowly pixelated for a moment before resolving. I leaned closer. The ear in the photo was smooth. I told myself angle mattered. Lighting mattered. Weight loss changes how features sit. All reasonable explanations. None of them settled the discomfort that had already taken root. I scrolled through the rest of the chart, looking for anything that might explain the discrepancy. Past imaging, prior surgeries, notes from the hospital. There was no mention of cranial injury, no procedures that would account for it. I checked the identifiers again. Name, date of birth, medical record number, everything matched. The system didn't flag anything as inconsistent. I tried to access the earlier versions of the record, the ones created during the hospital stay before the hospice transfer. The interface hesitated, then loaded a summarized view. The option to view previous versions wasn't available. That happens after records are merged. Hospitals consolidate data constantly. When patients move between systems, duplicate records are combined to reduce errors. It's a routine process, one that usually improves accuracy. And unless you're trying to see what existed before the merge. I called IT support and asked if they could grant me access to the original hospital record view. The technician was polite but firm. That level of access required administrative approval. I thanked him and hung up. I walked down the hall to compliance again, choosing my words carefully. I explained that I had noticed a physical detail that didn't appear in the admission photo, and wanted to confirm that the identifiers had been verified correctly. The compliance officer listened, then asked a question I hadn't expected. "Are you suggesting this isn't the same patient?" I said I didn't know. I said I wanted to make sure. She told me the identifiers had been verified at transfer. 2 forms of identification: family confirmation, wristband, chart review. Everything required had been done. I asked if the original hospital intake photo was still accessible. She checked, then told me the record had been merged during the transfer process. The current version was considered authoritative. That word mattered. Authoritative. Once a record becomes authoritative, discrepancies don't exist unless they're documented as errors. And documenting an error requires evidence. I returned to Richard's room with a weight I hadn't carried before. He was awake watching me as I approached. I didn't mention the mark. I didn't examine it again. I asked how he was feeling. He shrugged, the movement slight. I asked if he remembered anything from before the hospital. Not recent memories, long-term ones. He closed his eyes for a moment, then said, "Some things." I asked him if he remembered hitting his head at any point. He didn't answer. He didn't deny it either. I asked if he had ever had surgery on his skull. He smiled faintly and said, "Not like that." That response didn't clarify anything. It also didn't sound confused. I stepped out and checked the family consent forms again. Richard Hale, wife signature, son signature. Dates and times correct, no alterations. I called his wife and asked if she could come in later that day. I framed it as a routine check-in. She agreed without hesitation. When she arrived, I asked her about his medical history. She confirmed what the chart said. No major head injuries, no surgeries, nothing that would explain the indentation. I asked if she remembered the intake photo being taken. She said yes. She had been present. She said it looked like him. I asked if he had lost weight recently. She said yes, but not enough to change his features dramatically. She didn't seem defensive. She didn't seem confused. She seemed tired. I didn't push further. Back at the workstation, I attempted to view the audit log for his record. Audit logs track access and changes, not content. I could see that the record had been updated during transfer. I could see timestamps. I could not see what had changed. I called the hospital medical records department again, asking if there had been any duplicate records for Richard Hale. The clerk checked and told me there had been 2 entries initially merged shortly after admission. That was not uncommon, she said. Patients transferred emergently sometimes get registered twice. I asked if I could see the unmerged entries. She told me those were no longer accessible. I leaned back in my chair and stared at the screen, the system quietly reinforcing its own conclusions. The patient was Richard Hale, because the system said he was. The record was correct because it had been finalized. Any discrepancy that couldn't be documented didn't exist. I went back to Richard's room one more time that evening. The light was low. The unit was quiet. I stood at his bedside and looked at him. Really looked at him, not as a patient, not as a case, but as a physical presence. The indentation behind his ear was still there. I asked him softly, "Who am I taking care of?" He watched me for a long moment before answering. "The one they brought," he said. That answer didn't contradict anything. It also didn't confirm it. I documented nothing about the indentation. I documented nothing about the conversation. There was no place to put it that wouldn't sound speculative. As I left the room, I realized that whatever uncertainty I was carrying now wasn't about recovery or prognosis or awareness. It was about identity. About the possibility that somewhere between hospital and hospice, something had been simplified, merged and accepted, in a way that no longer allowed for verification. The system didn't need to know who Richard was beyond what the paperwork said. It only needed the paperwork to be consistent. And for the first time since I'd started practicing hospice medicine, I understood how easily a person could become whatever the record required them to be, as long as no one insisted on looking too closely at the parts that didn't line up. Richard died just before dawn quietly, without any of the signs people usually associate with the end. No agitation, no labored breathing, no last-minute surge that draws staff into the room. A nurse noticed the change during a routine check, confirmed the absence of breath and pulse, and called me in the way hospice calls are always made, calm and procedural. I stood at the bedside and performed the exam. No response, no respirations, no heart sounds. Time of death documented. The system closed around the moment the way it always does, efficient and precise, turning a person into a series of completed steps. His wife arrived an hour later. She cried, but not the way people cry when something unexpected happens. It was the controlled grief of someone who has been preparing herself for a long time. She thanked the nurses. She thanked me. She asked if he had been comfortable. I told her he had been. That was true. There was no autopsy. Hospice deaths rarely involve them. There was no indication for further investigation, no sudden change that would raise concern. On paper, the case ended exactly as it was supposed to. I completed the death certificate using the diagnosis provided by the hospital. Hypoxic brain injury, cardiac arrest, natural causes. The form accepted the entries without hesitation. When the body was transferred, the indentation behind his ear was still there. No one else commented on it. No one else was looking for it. By mid-morning, the room was being prepared for the next admission. Fresh linens, disinfectant, neutrality restored. Hospice doesn't linger on what's finished. It can't afford to. I went back to the workstation and closed Richard's chart for the final time. The EMR prompted me to confirm that all required documentation was complete. I checked the box. Case closed. The rest of the day passed in routine tasks. Other patients, other families, other endings. I functioned the way I always had, moving through the unit with practiced competence. But something fundamental had shifted. I felt it most clearly when I caught myself hesitating before signing orders, rereading notes that didn't need rereading, double-checking things I had never questioned before. That night at home, I didn't sleep. I kept thinking about the way the record had absorbed everything that didn't fit and smoothed it into acceptability. About how easily awareness had been reclassified as irrelevant once it no longer served a purpose. About how identity had been treated as a fixed data point rather than something that required maintenance. I thought about consent. Consent is supposed to protect patients. It's supposed to ensure that care aligns with values and wishes. But consent assumes a stable understanding of who is giving it and what it applies to. Once that understanding is recorded, the system treats it as permanent. Richard had never revoked hospice. He had never asked for treatment. He had never asked to leave. He had simply existed in a way that complicated the meaning of the documents I relied on. Over the next few weeks, I noticed changes in myself that I couldn't ignore. I was slower to reassure families. I was less certain in my language. I found myself watching patients' faces more closely than their charts, listening for meaning, where the system had trained me not to. That kind of attention is not sustainable in hospice. Hospice requires a specific kind of trust. Trust that the decisions made upstream were sound. Trust that the documentation reflects reality closely enough. Trust that once the process is in motion, it doesn't need to be questioned. I no longer had that trust. I began waking in the middle of the night, replaying conversations in my head, wondering how many times I had accepted certainty because it was easier than confronting ambiguity. I wondered how often I had mistaken silence for incapacity. I wondered how many patients had been present in ways the system had no use for. None of those questions had answers. That was the problem. I requested a meeting with administration and explained that I needed to step away from inpatient hospice care. I didn't accuse. I didn't describe Richard's case in detail. I framed it as professional burnout, a need for a different setting. They accepted my explanation without pushback. People leave hospice all the time. The work isn't for everyone. I transferred to an outpatient palliative role, where patients speak for themselves, where decisions are revisited frequently, where consent is an ongoing conversation rather than a completed form. Life became quieter after that, more predictable. I slept again. But something stayed with me. Every so often, I catch myself thinking about the space between hospital and hospice, that narrow corridor where records are merged, decisions are finalized, and people become categories. I think about how easily the system resolves uncertainty by declaring it irrelevant. Richard didn't frighten me because he knew things he shouldn't have known. He unsettled me because he exposed how much of medicine depends on agreement rather than understanding. In hospice, we say no one should die alone. We mean physically, emotionally, spiritually. What I learned is that no one dies outside a system either, and systems don't require comprehension to function. They only require compliance. Richard complied with everything that was asked of him. He didn't resist. He didn't demand. He didn't disrupt the process. He simply existed at its edge, aware enough to notice what it was doing, and quiet enough to let it continue. I still practice medicine. I still believe in comfort. I still believe in dignity at the end of life. I just no longer believe that paperwork tells the whole truth. Somewhere between a hospital bed and a hospice room, a person can become whatever the record says they are, and the system will carry that version of them all the way to the end, confident in its own certainty. That confidence is what finally made me leave. I still think about that case more than I should. Not because it was dramatic and not because it had answers I missed, but because it showed me how easily certainty can replace understanding in medicine. In hospitals, we rely on systems to move fast and be decisive. Doctors are trained to trust documentation. Nurses are trained to follow protocols. That trust is what keeps healthcare functioning at scale. But sometimes, in between the checklists and the signatures, something human doesn't fit cleanly, and the system keeps moving anyway. That experience didn't turn me against hospice, or against doctors, or against nurses. It made me more aware of how fragile judgment can be when it's built entirely on records instead of presence. The most unsettling nurses' stories and doctors' stories aren't about monsters or miracles. They're about moments when everyone does their job correctly, and something still feels wrong. If you've ever worked in a hospital or been close to someone who did, you probably understand that feeling. The sense that medicine isn't just about knowledge, but about what we choose to notice and what we choose to let pass. If stories like this matter to you and you want to hear more real-life hospital stories centered on doctors and nurses, consider subscribing to the channel. These aren't stories meant to scare you. They're meant to stay with you the way certain cases stay with the people who live them.